Surprise, surprise, that's great. I'd like to bring up our next speaker, Dr. Sarah Chavez. Dr. Chavez is the Assistant Director of Community Outreach and Engagement at the Alvin J. Siteman Cancer Center, Division of Public Health Services, Washington University School of Medicine. Dr. Chavez has an eclectic background, which includes prior study in Scotland, where she worked with the team that did the original cloning of Dolly the sheep, for those of you who may remember that one. Dr. Chavez has extensive experience with AI and was recently awarded a Marion G. Horchman online teaching innovation grant for her work on leveraging AI instruction. We will either hear many different ways to cook lamb chops, or we're going to hear about the exploration of the revolution of AI tools in lung cancer care. Either way, I'm sure it's going to be interesting.
Hi, thank you so much. I'm hoping I'm loud enough. I have 6 kids, so I'm usually loud enough. So I too got into cancer because of a family connection. I lost all 4 of my grandparents to cancer. I lost my grandmother, who I'm named after, on my 15th birthday. And pretty much immediately after that, I said, I'm gonna figure out what is going on here. I'm gonna figure out, I'm gonna figure this out. And so I decided I was going to be a scientist, pretty much right away. So when I started doing research, I really quickly realized that the work that we're doing is so important, but it always bothered me that not everybody could get it. Like, who has access to all of this great work? So that kind of is what drove me into this area. And I can tell you right now, when I lost my grandma, she had a smoking-related cancer. She had already survived breast cancer, and the smoking finally was what took her life. But there are so many cool things on the horizon. I don't want anyone to feel discouraged by it. So that's kind of the framework I picked for my presentation. Okay, next slide. Okay, so like any good teacher, I'm like, what can I do to learn more about what's going on? Because this field is moving so fast. So what I did is I actually used a couple of the tools I teach my students to use, and including some of the high school kids I work with. There's a really fun program you can use if you want to learn more about this. Through Notebook LM, you can actually upload the really complicated stuff that you find, all of these studies and papers, and then just ask it simple questions. So that's kind of what I recommend for people who are trying to figure out what to do, and for some of these really heavy technology areas, kind of how to get started. Next slide. So what I found is, in searching this, there were actually about 50 really good new studies that are telling us what's on the horizon as far as AI goes. Okay, next slide. So these are the 4 basic areas that I think we're really going to see AI and these new technologies coming into play. The first being the ability to detect and kind of monitor those nodules that we've been talking about. So from my perspective, being in community outreach, we want to make sure people are getting their lung cancer screenings every year, because that screening and detection, we can follow that same nodule. We can make sure we're keeping a close eye on it. So we really try to make sure people return for that next appointment. We don't just want it to be a one-time thing and then we never see them again. Diagnosis is also really important. And I'll kind of get into some of the aspects that are happening around here in Missouri around the diagnosis part. But then once we move into treatment and planning, that's really where they can start to use the AI to give you better predictions about whether or not you're actually going to respond to different immunotherapies. And I'll be able to give you like a solid example of that. And then finally, the prognosis and the follow-up, because we all want to know, if you are diagnosed, like, how bad is it? What do I have to expect? And I think that's a big open area. You're planning for your future. You're planning how much time you have with your family members. We want to give you the most accurate information we can. Next slide. So this is kind of where we're at right now. Ideally, people are getting all this biomarker testing. What really happens, though, is sometimes you're not actually getting the right amount of testing or the right type of testing. So about half of newly diagnosed patients with non-small cell lung cancer did not receive any type of biomarker testing right before COVID. And then about 30% didn't get the appropriate amount of testing. So even when we're talking about what percentage of people get biomarker testing, that doesn't mean that they actually got the right type or the full panel, like the full possibility of what they could get. Okay, next slide. So the first thing I looked into is that sort of that detection and the classification. When you look at using AI, what they're doing is they're basically feeding these images into a system and letting the AI tools supplement what the radiologist is doing. So if you opt into this, it's not like you're saying, I'm not going to get a doctor, the computer's going to diagnose me. That's not what's happening. What they're doing though is that they're looking at like different pixel counts. They can look at that density, that sort of fuzziness, and they can assess whether or not that nodule is more or less likely to be cancer. And when they compare that against the human results, it's so far the sensitivity, the ability to accurately diagnose is about 86%, but also the specificity. And the difference between the two is, are you going to get a false positive? Are you too sensitive and you're telling everybody they have cancer when really they're not? Or are you not sensitive enough? Is the specificity not, is that, if that's really low, it means that the bar is set higher before you get a positive diagnosis. But it's doing really, really well with these new AI tools that they have to upload your images through. Next slide. And here's kind of the image that I was able to find. What they're doing with most of these imaging technologies is they're taking that tumor and they're actually comparing it at the pixel level. And these are things that even the best radiologists, the human eye cannot detect it. So from our perspective, through the Lung Cancer Coalition, we want to make sure everyone in Missouri gets this because this is the type of scanning, the use of that technology to read people's lung cancer screening is going to be a huge difference maker in the future. It's going to make sure that the results we're giving you are super accurate and that we're detecting it as early as possible. Next slide. Okay, so the next thing, and this is something that's really important to me personally, being a molecular biologist in my training, is the biomarker testing. They can do a lot of these really cool digital pathology. So if you get diagnosed in rural Missouri and there's not a big hospital to do these types of pathology, they can create the slides, upload it somewhere, and someone else can read the slides for you. So it really does change things as far as who gets access to the biomarker testing. And the same thing with these radiology images. If they can go into the cloud to where your doctor or your radiologist doesn't have to be at the hospital next door, it's a great asset for a lot of our patients. Next slide. Okay, and then what I was mentioning about that difference maker in the additional images. So this is looking at that sort of risk stratification, like what is the chances of this, are you like a high risk tumor or a low risk tumor? And the more scans you get, the more accurate they can get. So if you're continuing to get your lung cancer screenings year over year, they're going to be able to distinguish between whether or not you're a high risk for lung cancer or a lower risk. Next slide. So this is where it gets complicated with all this biomarker testing and the genetics. They're all this alphabet soup of all these gene names that they throw at you. And we all know that, at its very heart, cancer is genetic. It's something in the DNA that is messing up. It's getting the recipe wrong. I always describe, it's like a recipe box. I have my grandma's recipe box and I refer to it all the time. But if the recipe gets written wrong, if the mutation causes an error and, some part of the recipe gets deleted and you make too much or not enough, or if you substitute the wrong ingredient, it's all about that preciseness of the recipe. And any number of things, including smoking, can mess up that recipe. Next slide. So the best analogy for this, really, for biomarker testing is your check engine light. Like, I don't know how my car works. My husband loves to remind me of the time I asked him what the genie lamp meant because it was flashing at me. Like, that's where I am with cars. And that's how a lot of people are with all of this mess up here. It's really complicated stuff. But think about it like this. If your car doesn't start, it can be any number of things. It could be you're out of gas, the battery's unplugged, there's a number of things that could happen. When you take it to the mechanic doesn't just say, well, I'm gonna change the battery. Like, they're going to do some tests. They're going to run that diagnostic test and they're going to figure out exactly what's wrong with your car. They're not going to assume it's the most obvious thing or like, oh, I'm going to change your oil. That didn't fix it. Now I'm going to do this. That didn't fix it. They're going to first look to see what's actually wrong with it before they start trying to fix it. That's what biomarker testing is. Because you can see all these different colors, it basically represents the order that the mutations happen in the cancer. Everybody's cancer is different. We're all unique in that way. We've done studies where we've looked at the pattern of the mutations that people's cancer have, and they are very different. It's not a one-size-fits-all approach when we treat people. But if we give people access to biomarker testing, what we're doing is we're doing that extra diagnostic workup before we get you started and put you on a treatment that's not likely to fix the actual problem. We can get you the right treatment right away. Next slide. Okay, so just to illustrate this from a personal experience, both my father and my uncle were diagnosed within months of each other with lung cancer. My dad got his low-dose CT reluctantly. He was kind of a brat about it, but I convinced him to go because he was a current smoker and didn't want the lecture. That was his rationale. They caused the most aggressive type of lung cancer at stage 1. And had he waited, had he put it off 6 months, it would not have been a good outcome. My uncle, on the other hand, he too was a smoker my whole life. Both of them were smokers. He had been having symptoms and hadn't told anybody about it for a really long time. And by the time he was diagnosed, he was stage 4. And this is actually one of the pathology reports that we had as a family, because we also, in addition to our lovely history of lung cancer and smoking-related cancers, we carry the BRCA mutation for breast cancer. And as carriers for that, this is the type of information they give you. And no normal person knows what any of this means, but this is literally what they hand you as you are walking out the door. And they're like, here's what it says. And they basically say, you're positive. Good luck interpreting what any of this gibberish means. Next slide. So when we're talking about he got that, when we get that test, that genetic test, but you also get a biomarker test, there are two different things that they're looking for. A genetic test, like the BRCA test or something, is going to tell you what you were born with. Like, were you born with a genetic predisposition to cancer? A biomarker test assumes you have cancer, and they're looking for what's wrong with that particular cancer. And so sometimes people think they've had biomarker testing when really they've had the genetic testing, or vice versa. So if you have a family history and you are concerned about that, be sure to mention that, even if it's lung cancer. Smoking runs in families too, but that genetic piece, he hadn't thought to mention he was a carrier for BRCA, but by knowing that, it opened up a lot more treatment options for him. So it is a combination of what's going on with your tumor, but also these other kind of personalized factors that could affect ultimately your treatment outcomes. Next slide. But this is where we stand with biomarker testing here in Missouri. We don't do a great job. For a lot of this reason, why we're not getting very high rates of biomarker testing is that not all insurance will cover it. Not everyone offers it. And sometimes not everybody's a candidate for biomarker testing if you have very late stage lung cancer. But even if you take that out of it, these rates are really low. We need to increase the amount of biomarker testing that's done across our state and do a better job at that, because it's like we're trying to fix cars without actually knowing what's wrong with them. Like, that doesn't make any logical sense. Next slide. So there is current legislation here before the Missouri Senate. So let's all, if you know someone in the advocacy world, this is the type of thing that goes under our radar. And most people see that and they're like, why do I care about that? There is this new legislation. It failed last year, but it's back on, and they're hoping to make it part of the law that insurance companies, including Medicaid, should cover biomarker testing for all patients. This is how we change and improve some of these inequities that we've been talking about. We need to make sure everybody gets this, because that's going to get you routed to the best care for you. Next slide. So this is, you actually have some information, I believe, in the packet, but this is a really good report that was put out recently. And we actually use this to kind of frame some of the work that we do at the state. So they were basically trying to understand what's the ecosystem here in St. Louis and here in Missouri as a whole. How well are we doing in the lung cancer space? Where are some things that we can be doing better? And once this got published, our team, I'm part of the Missouri Cancer Consortium. We're a bunch of folks from all over the state who are trying to improve cancer care for people by fixing policies that are broken and fixing systems that are broken by sharing ideas and trying to elevate people's concerns to the people who can actually change things. So once we got this information, our team really ran with it. Next slide. So this is the best way to get involved. If you are a lung cancer patient, if you are a caregiver, if you're just a concerned citizen, we have a new group that we've been pulling together over the last few years called the Missouri Lung Cancer Coalition. We have been working tirelessly to try to improve the state of lung cancer here in Missouri and basically trying to idea share. We've been trying to pull together, so we need to know what's not working for you. If something isn't working, tell us. We will chase it down. If you just need a support group, contact us. We will help you with that. One of the projects that we have that we are really hoping to get off the ground in the next 6 months here is a radon, is our work with radon, as everyone has been mentioning. We are planning to implement a library lending program where we can have these little snazzy things in the libraries and you can actually go rent it and pick it up and take it home. And yeah, that's how you fix things. And those things, I've priced them out. They are in my cart right now. You can get a cheaper version of that that's just as good based on the data for like $150. But if we can put a few of those in the libraries, we're going to start up near North County because I'm also super involved with all of the RICA work because that's a whole lot of craziness happening up there. And we know there are high radon levels up in that neighborhood. So we're going to start in some of our local libraries, but also reach out to folks down in the Boot Heel and, other parts of the state and start sharing these. But we want to not only have it to where you can check it out, but then once you get a positive result, what do you do about it? We're going to have a team pulled together to help you through the next steps. And actually, through our work with the coalition, we've actually have legislation pending for a radon bill in the Missouri House. And it has bipartisan support, which is amazing. No, you never get that. But in the state of Missouri currently, I have to have a license to cut your hair. I have to have a license to shave your dog. I don't have to have a license to mitigate radon in your house. I could claim I'm a radon mitigation specialist and there is no one to check. We're trying to fix that so that when you get a positive test and you give somebody $1,000 to fix your house, you can be sure that they know what they're doing and that they're actually qualified to do that they're not just selling you a batch of hooey and it's not actually going to work. So those are the types of things that we recognize the need as a team. And we're like, well, and it comes from the testimony of individuals who say, I got my home mitigated and the radon's still there. I got it retested. What the heck's going on? So we hear from people about things that are happening, and then we're trying to make a difference by changing the systems that are broken and just making these tests more accessible. But if you need a radon test, reach out to us. We are in pretty much weekly contact with the folks in Jeff City who actually distribute those tests, and we can find you a test. We will scour all of Missouri and find you a test if you need one. That's part of what we do is we're problem solvers. We try to share ideas across the state and figure out who's got what and who can fix this issue. Next slide. So, this is really where, as the whole scheme of things, this is where we're hoping to get. Right now, if we can get people in for screenings, and we have a 92% accuracy on these screenings if we supplement them and get them these AI tools, we can catch people early. My uncle, even though he was stage 4, is still doing great because of biomarker testing, because of knowing exactly what's happening with his tumor. If we were thinking about my grandma's situation, she was gone in less than a year. There was nothing that could be done. Here he is 4 years later, And he has all that extra time with his grandkids and with us. And the same with my dad that we missed out on because none of this was a thing back then. So much has changed in 20 years. So as we're looking at the roadmap, we need to think about, am I getting the best possible care? And is everyone getting the best possible care? Because it does us no good if we get these technologies and only people with really good insurance or a lot of money can afford them. That is not the solution we are looking for. I want to make sure everybody knows that this is a thing and has access to the technology. So, and ideally, we want to get to the point where we're starting to do more of these additional clinical trials. And that's where teams like our team at WashU, we're really involved in personalizing the whole process. We actually have a clinical trial going on looking at what type of smoking cessation works best for individuals based on your genetics. Because we know not everybody is successful at quitting smoking. And now we know some people are hardwired to respond to one treatment better than the other. But nobody does that test. They just give you the gum and say, good luck. But no, like that doesn't work. So wouldn't it be great if you knew the gum's never going to work for you because you're genetically, it's not going to work. This is what's going to work for you based on what's tailored to you and your individual biology. So there are a lot of these awesome clinical trials that are going on, but we need more. Next slide. So here is my contact info. If anybody has any issues getting radon tests or getting access to anything related to lung cancer or really anything cancer related, I'm part of the Program for the Elimination of Cancer Disparities. So you may have heard us as PCAD around here locally. But our team is tasked with going out into the community and then relaying the messages we get from the community back to Siteman so we can do better and we can make sure that our research is matching what everybody in the community actually needs. I'm happy that finally, we are getting a mobile screening unit for lung cancer. It is coming out this fall, so we are super excited to be able to bring the screening to people. But now we're doing the work as to trying to get people to show up when we bring the van down there. We want to make sure people know what they're getting into and that it's not just screening, it's what happens if the screen is positive. We have to be ready to help those folks. And that's where the Missouri Lung Cancer Coalition is going to come in. We're going to be that part that helps get you to Julie or get you to the right navigator. Because honestly, I don't care where you go. All of our partners in the coalition are from fabulous hospital systems. I would trust any one of them. So I'm not necessarily trying to pull people just to my cancer center. I want them to just get screened anywhere. And that's, we have this link called getscreenednow.com. If you go to that and you type in your zip code, it will tell you every place nearby that offers different types of cancer screenings. Because we don't care where you go, just go somewhere. And if you are having any issues, contact us and we will get you the help that you need. Okay, well, thank you.